Welcome back. On Viewpoint today, we revisit the Yoon administration's COVID-19 campaign, given its 100th day in office this week. For more, I have Professor Kim Moon-Kyu from Yonsei University here in the studio. Professor Kim, welcome back.
Thank you for having me.
I also have Professor Monica Gandhi at the University of California, San Francisco, live on the line. Professor Gandhi, it's a pleasure to see you again.
Thank you.
Professor Kim, it's been 101 days to be precise since the Yoon administration came into office, and on the pandemic front, his health officials have been promoting a strategy which they claim is based on rational science and not on rampant sacrifice. What is your assessment of their efforts thus far?
Well, I think Yoon administration had a good momentum to start and change some policies about COVID-19. Some has been achieved and some not yet. Maybe it's too early to talk about, but I'm still waiting for some results such as nationwide antibody results and some studies for long COVID. And I wish we can have more manpower on epidemiologic survey system. And if you look back of the 2 years of this pandemic, I remember Israel gave us a very prompt and almost real-time data, and they were very quick to get some vaccination program. So we have to learn how did they do that. So if we can follow some points that they did, I wish we can have our own Korean data. And actually, I'm more interested in long-term plans. So I don't have many words to talk about, but through this pandemic, we learned a lot of lessons. It taught us a lot of lessons. And for the quarantine policies, I think most of the countries had made some mistakes and learned something. There were many limitations and even adverse effects from those policies. And it's also affected almost all aspects of our life. So if you look back, as we didn't know much about the coronavirus yet, sometimes politicians intervene in the decision-making period and gave us some unrational rules. But I think now we don't have to worry about that because we learn more, we know more about the virus, and we have vaccine and we have medication. So if we can minimize fatalities and prevent the emergence of new variants, I think I will be satisfied.
Right. Professor Gandhi, the administration here in South Korea appears to have placed priority on treating critical cases to prevent fatalities. And this is instead, of course, staging an all-out prevention campaign. As a medical professional yourself, what are your thoughts on this particular strategy?
So I actually think the South Korean strategy that's being proposed is absolutely reasonable and rational. I'm an infectious disease doctor, and fundamentally, we cannot eradicate COVID. And this is not through lack of trying. And the reasons we can't eradicate COVID is because it spreads when it's pre-symptomatic, it has animal reservoirs, and it continually mutates. These are not the features that allow eradicability. The only eradicable virus that we've achieved so far is smallpox. 0 animal reservoirs. There's 29 species of animals that can contain COVID. So it's very rational at this point in the pandemic to just try to minimize severe disease. And the way to minimize severe disease is vaccination, and especially boosting older people, and probably yearly boosting of older people, and using treatments to prevent severe disease if you're susceptible to severe disease. Unfortunately, we cannot eliminate this virus, and I do think that the South Korea strategy is very reasonable.
Right, and moving forward then, Professor Kim, some health experts here in the country claim that an endemic phase of COVID-19 will be likely next spring if the fatality rate among the elderly is further controlled, of course. How do you respond?
Well, I think future is very hard to expect, and it's not the realm for humans. But I do expect, at least by next spring, pandemic phase will turn into endemic. And well, the general perception for COVID-19 has been changed a lot. because we are vaccinated, before some of us got infected, and because we have medications, I think people are getting off guards and becoming less vigilant. But we have to maintain minimum vigilance because I believe that we could have prevented the last 1 or 2 outbreaks if global health authorities had tried more to reach out the blind spots in our world map, such as Africa and India and some places. So, well, most of the hospitals in Korea, we are still struggling to find the proper beds for patients with underlying conditions who got COVID-19. And the daily tally shows that still we have hundreds of severe cases. I'm not sure whether all of them might be so severe because of COVID, or they might have their underlying conditions getting worse. In addition to that, they might have COVID-19. So anyway, we have to deal with those patients with very much precautions, and still we're struggling. So I wish that we can solve that problem before we forget the lessons of this COVID-19 pandemic.
Right, of course. Professor Gandhi, what are your personal thoughts with regard to a possible endemic phase of COVID-19 for the broader global community?
You know, the word endemic essentially means a level of illness that society can live with. And that is extremely difficult to define for a new pathogen. The difference between COVID and many of our other endemic pathogens like influenza, like adenovirus, rhinovirus, other enteroviruses, is that we have had great progress in COVID-19 that is unprecedented. We had a vaccine happen within 9 months of the pandemic. It doesn't mean that everyone took the vaccine, but we absolutely, and you have very high rates of vaccine uptake in Korea, but we have an excellent vaccine. In addition, we have treatments, which actually is very unusual. We don't have a treatment for adenovirus, for rhinoviruses, for other coronaviruses that affect older people and can actually tip them over if they have multiple comorbidities into, unfortunately, mortality. So older people are very susceptible to even mild respiratory infections, but we don't have treatments. We do have treatments for COVID-19, and more are coming. We have Paxlovid, we have molnupiravir, we have monoclonal antibodies. So to reduce the mortality of this infection, we actually have to apply those treatments as much as we can. We have to use them, think about older people as being very susceptible to severe disease, and use them. Use Evusheld or monoclonal antibodies to provide for pre-exposure prophylaxis for people who are susceptible. It's an ongoing, active, always working process. So endemic may mean the public can relax and not always try to prevent transmission, but the medical system will always be applying these tools to keep the severe disease as low as possible.
Right, and staying with treatment and vaccines, Professor Kim, here on the local front, a new COVID-19 vaccine, new Vaxovid, has been approved by authorities here for those aged 12 to 17. What more can you tell us about this particular vaccine?
I'm very interested in it because it is more well known as a Novavax vaccine, and it's a protease subunit vaccine, or you can call it recombinant nanoparticle vaccine. It is very stable. You can store it in 4 degrees Celsius at about 6 months, and even though you put it in 25 degrees, it's stable for 12 hours. So you can say that it's very easy to deal with, storage. And as I mentioned, there's many countries lack of electricity and deep freezer. So RNA vaccine is not suitable in that situation, but this vaccine is very stable. It started its phase 3 trial in March September 2020 in UK. And it was introduced in United States and started its clinical trial for 12 to 17 years of age at March 2021. And South Korea was it was introduced to South Korea this January, and actually many people who got some trouble with AstraZeneca or RNA vaccines, they could switch to this Novavax vaccine because it was quite stable with less side effects. And for children or adolescents, because they have less severe infections, even though they get infected, it's very hard to persuade the parents if the vaccine itself has a serious side effects. So I'm very glad that it is approved for adolescents, and I wish that it can extend to even younger children. And actually, we know that the vaccine cannot prevent the infection completely, but it can prevent severe cases. If the effectiveness of vaccine remains to prevent severe infections, I think this Novavax vaccine will be a proper choice, especially for children.
Right. Professor Gandhi, beyond Korea and over in the US, I hear new quarantine guidelines by the CDC there have divided the medical community in the US. Could you tell us a bit more about that, and where do you stand on that particular matter?
So this was just recently CDC updated guidance for schools, but it had a lot of implications for managing the pandemic. The guidance is essentially saying you don't have to quarantine if you've been exposed. Vaccinated and unvaccinated people are essentially the same in terms of their quarantine recommendations, and isolate for 5 days if you have COVID. And only wear masks in settings of high community prevalence. So it has divided the medical community. There are those who said we should try harder to stop transmission. And there are others that say we have the biomedical tools to prevent severe disease. And these tools to prevent transmission, like masks, like distancing, have actually their own costs, their own societal costs. For example, our schools have been closed for some of the longest periods of time compared to schools in other European and UK counterparts. I stand on that. I actually think the CDC guidance makes sense. And the reason is it's sort of like the South Korea guidance. It's a rational roadmap accepting the reality that we cannot eradicate COVID. It is bringing COVID into other respiratory pathogen management. And it's saying that we have to live with it, but our main goal in life is to try to reduce severe disease through vaccines and therapeutics. So it is controversial right now in the US, but I think that ultimately the US population, just like Europe, just like UK, just like South Korea, will eventually accept that we have to live with the virus.
Right. And speaking about South Korea, Professor Kim, when do you expect our current wave to perhaps peak? Authorities have spoken about it peaking sometime this month after hitting above 200,000 daily cases. What are your thoughts?
Well, it will rise for a while. It didn't reach the peak yet. Since last June, it was interesting that Korea and Japan was having the same outbreak. Maybe it's because of the BA.5. And it started in the same time, and the speed of increasing was almost same. And it maintained this pattern until recent weeks. But right now, the 7-day average per million of the daily tally is about 2,400 for Korea, but Japan has decreased to 1,500. So I don't know why there is a difference, but maybe there might be a difference in herd immunity. I mean, some patients infected but not reported, or there might be some difference in the number of tests done between those two countries. Anyway, it will take a few more weeks, and right now the majority of the infected cases are those people who were not infected before. So I think the point of decline will be the time when all susceptible subjects are infected, and maybe there might be some few reinfections. And there are many data that there are some persons who are not getting infected with COVID-19, even though they are exposed many times. I don't know how much are they, but I think it's will be very small in number. The cumulative number of COVID-19 in Korea already passed the 21 million, and yeah, it would take a few more weeks to reach the number.
Right, I see. Professor Gandhi, staying with transmission trends, what can you tell us about the actual COVID-19 situation there in the US?
So we also, just like you, BA.5 is the latest variant. It's essentially more than 90% of our strains. This is actually a subvariant of the Omicron variant, and led to high number of cases, but actually there was quite a decoupling between cases and hospitalizations. Many of our hospitalizations are misclassified because we swab everyone who comes into the hospital with COVID-19, but they may not be sick with COVID-19. They have it in their nasal swab because they're such high cases. There's actually been much lower rates of COVID pneumonia, and as marked by ICU admissions, which is for us the most clear marker of severe disease. With this degree of population immunity, we have much lower rates of severe disease. Where's this population immunity coming from? It's coming from vaccination. That would have been the best way to get it. But it's also coming from high rates of natural infection. Throughout COVID, throughout the Omicron variant surge, we had a lot of natural infections. So that's why actually the CDC decided not to distinguish between vaccinated and unvaccinated people in terms of quarantine recommendations, because we have so much natural infection. We had 60% seroprevalence in adults and 75% seroprevalence in adults, as recorded by the CDC on April 26, which reflected data up to February. We've had so many Omicron infections since that we likely have a much higher seroprevalence rate. So that has led to much lower rates of severe disease. We can bring that severe disease down even more if we apply our therapeutics more appropriately, and if we apply our pre-exposure prophylaxis monoclonal antibodies in a wider fashion. And now those are moving on to private insurance, and I hope that people will be using them more.
Right, I see. And Professor Kim, speaking within your capacity as a doctor yourself, what are your words of advice to the Yoon administration as it seeks to chart a safe path out of this pandemic?
Well, I would like to mention two things. Because it's been more than 2 years of pandemic. Already we are experiencing a chronic shortage in manpower in intensive care units, emergency departments, and other departments dealing with severe cases with big operations. So this is the time we evaluate and empower those weak points. And the second point is in Korea, we have a big metropolitan area, and we have many hospitals and doctors, but in rural area, sometimes it's very difficult to find a proper treatment, doctors who are ready to take care of them. So I would like that this government will evaluate those points, and we have to improve these weak points when we know and understand this.
Right, a stronger medical framework perhaps than for the rural areas of the country. Professor Gandhi, I extend the same question to you. What are your words of advice as a medical professional and professor looking into the situation here in South Korea from the outside?
So personally, I actually think South Korea sort of did everything right. This has always been my opinion about South Korea. They worked really hard on trying to reduce transmission of the infection prior to the vaccines. Then there was more trust than we unfortunately had in the US in terms of vaccine uptake. And you had high rates of vaccine uptake, including, as you said, Novavax for the younger people. But importantly, you did a very good job in boosting older people. Older people need more than 2 doses. That has been really shown by the hospitalization rates during Omicron. And there was a very concerted campaign to boost older people in South Korea. And then the acceptance that we can't prevent all mild infections, but that we have to work on severe disease, I think was accepted by South Korea very after the vaccine campaign. So I sort of watch the South Korea trajectory, in my opinion, as a very reasonable response throughout the entire pandemic.
Right, Professor, thank you so much for your kind words, and thank you for your time today as well. And Professor Kim here in the studio, thank you very much for your insights.
Thank you.